Welcome to our deep dive into the hidden world of medical isotopes. You might think radioactive atoms sound like sci-fi, but over 50 million healthcare procedures each year hinge on these invisible powerhouses. Today, we unpack the global state of medical isotopes 2025, exposing how tiny particles revolutionize diagnosis and destroy cancer, and why the supply chain is a heart-stopping race against time.
Absolutely riveting introduction. As a lawyer who's tangled with nuclear regulation for decades, I've seen how every technical choice intertwines with policy, trade wars, and safety rules. These isotopes, radioisotopes in the official parlance, are the lifeblood of nuclear medicine, used for imaging organs and zapping tumors. Our challenge is explaining complex production and logistics in plain terms.
Let's start with the basics. The document divides isotopes into diagnostic versus therapeutic. Diagnostic isotopes create images, think single photon emission computed tomography, known as SPECT, and positron emission tomography, known as PET. What makes one isotope diagnostic?
Diagnostic radioisotopes emit radiation that cameras or detectors pick up externally. They're short-lived, minutes to days, to minimize patient exposure. Technetium-99m, with a 6-hour half-life, is the workhorse of SPECT, used in about 80% of nuclear medicine procedures worldwide. For PET, positron emitters like fluorine-18, half-life approximately 110 minutes, are attached to glucose to image cancer metabolism.
I love that image. Glucose glowing to show us tumors, so those tracers go in, they highlight physiology, and then they vanish. Meanwhile, therapeutic isotopes are killers, delivering lethal radiation doses to diseased tissue.
Exactly. Therapeutic radioisotopes emit particles, beta or alpha, that deposit energy across millimeters or micrometers, killing cancer cells. Iodine-131, with an 8-day half-life, targets the thyroid. Lutetium-177, half-life 6.7 days, binds to neuroendocrine tumors. Radium-223 mimics calcium to attack bone metastases in prostate cancer. Some isotopes do double duty, small iodine-131 doses for imaging, higher doses for therapy.
You mentioned brachytherapy, implanted seeds of iridium-192 or iodine-125 in tumors. That's such a horror movie image, but also brilliant. Killed the tumor from inside while sparing healthy tissue.
Brachytherapy is indeed a marvel of focused treatment. Iridium-192 seeds deliver high-dose radiation over weeks. Iodine-125 seeds in prostate cancer quietly irradiate the gland, minimizing collateral damage. It's a marriage of precision physics, radiochemistry, and surgical placement, backed by strict regulatory oversight.
Now, let's talk production. The document lays out 3 main methods: reactor-based, accelerator-based, and generators. Start with reactors, fission and neutron activation.
Reactor fission uses uranium-235 targets, now low-enriched to under 20% U-235, to produce isotopes like molybdenum-99 via fission fragments. Molybdenum-99 decays to technetium-99m. After irradiation, hot cell chemists extract MO-99. Fission yields high specific activity, crucial for generator performance, but generates high-level radioactive waste requiring solidification and on-site storage.
And neutron activation?
You bombard stable precursors with neutrons. For example, lutetium-176 becomes lutetium-177. Ytterbium-176 becomes ytterbium-177, decaying to pure lutetium-177, avoiding long-lived impurities. Activation also makes cobalt-60, used in therapy machines and sterilization. Activation is great for certain therapeutic isotopes, but cannot satisfy large-scale Mo-99 demand because the specific activity is too low.
Then cyclotrons, the particle accelerators in hospitals that churn out PET isotopes daily.
Cyclotrons accelerate protons or deuterons into targets. Fluorine-18 is made by bombarding oxygen-18 enriched water. Carbon-11, nitrogen-13, oxygen-15 come from gas or water targets. Cyclotrons also produce iodine-123 and thallium-201 for SPECT, and gallium-67 for infection imaging. Because these isotopes decay in minutes to hours, production must be close to the clinic.
What about generators, those technetium cows?
Generators use a long-lived parent isotope decaying to a short-lived daughter. The classic is the molybdenum-99 Technetium-99m generator. Mo-99, with a 66-hour half-life, is loaded on an alumina column. As it decays, Technetium-99m elutes with saline. Hospitals get daily elutions for 1 to 2 weeks. Others include strontium-82, rubidium-82 for PET cardiac imaging, and germanium-68, gallium-68 for neuroendocrine tumor scans.
This is a marvel of chemistry and logistics, but that brings us to the heart-stopping challenge, supply chain fragility.
Yes, reactor infrastructure is aging. Reactors like the high-flux reactor in the Netherlands and BR2 in Belgium date to the 1960s. Unplanned outages trigger global shortages. MO99 decays at 1% per hour. There's no stockpile. It's a just-in-time cycle from reactor to patient. Transport delays, customs, or even volcanic ash clouds can force scan cancellations.
I read about the 2-week TC99m shortage in 2009 and 10 when multiple reactors went offline. Heart scans and bone scans were postponed worldwide.
That crisis sparked the Organization for Economic Cooperation and Development Nuclear Energy Agency's high-level group on security of supply of medical radioisotopes. They recommend outage reserve capacity, standby production, but paying for idle reactors is economically painful, and converting from highly enriched uranium to low-enriched increased costs by up to 30%.
Then there's geopolitics. Russia supplies high-assay, low-enriched uranium and isotopes like cobalt-60, and sanctions could jeopardize supplies. Europe is scrambling to localize HALEU production. The United States has funded NorthStar and SHINE to build domestic Mo-99 capacity with non-fusion methods.
Exactly. NorthStar uses neutron activation of molybdenum-98 and a low specific activity generator system, licensed by the Food and Drug Administration. SHINE uses a subcritical solution of low-enriched uranium driven by a fusion neutron source. When fully operational, SHINE aims for 1/3 of global Mo-99 demand. Canada's Bruce Power is irradiating ytterbium-176 in CANDU reactors for lutetium-177, processed by ITM in Germany.
And new reactors like the Jules Horowitz in France, the Pallas in the Netherlands, RA-10 in Argentina, and KJROV in South Korea promise fresh capacity, but years in the making.
Precisely. Those reactors will replace aging units in the mid-2020s. Delays extend our dependence on old infrastructure. In parallel, cyclotron production of Technetium-99m and accelerator-driven Mo-99 production are emerging as backups, though higher cost per curie remains a hurdle.
Let's talk market trends. Diagnostic demand has plateaued in some regions due to alternative imaging, but radiotheranostics are booming. Lutetium-177 therapies like Lutathera and Pluvicto fueled a spike in demand. Actinium-225 for alpha therapy is in trials, but supply is extremely limited.
Indeed. Radiopharmaceutical giants like Novartis and Bayer now invest directly in isotope production to secure their therapies. Novartis acquired companies producing Lutetium-177, dotatate and PSMA therapies, tying the drug pipeline back to the source of isotopes. This vertical integration underscores how critical supply security is for multi-billion-dollar markets.
What about waste and environmental concerns?
Fission-based production yields high-level liquid waste that must be solidified in glass or cement. Neutron activation and cyclotron targets generate lower-level waste, contaminated consumables and spent columns. Regulatory agencies control how much waste accumulates on-site and require licensed disposal pathways. In South Africa, NTP mixed Mo-99 waste with cement and shipped it to a specialized facility, an approach not universally available.
It's astonishing how many moving parts there are, from nuclear physics to couriers rushing across borders under time pressure. Who are the key players on the global stage?
Major actors include ANSTO in Australia at the Opal reactor, NTP radioisotopes in South Africa at the Safari 1 reactor, Institute for Radioelements in Belgium, Curium in Europe and North America, Nordion in Canada, Rosatom's JSC isotope in Russia, and ITM in Germany for no-carrier-added lutetium-177. New entrants like NorthStar and SHINE in the United States, Canadian nuclear laboratories and Bruce Power in Canada, plus private logistics firms like Cardinal Health, make up the network.
So what's our bottom line for listeners? Will patients face isotope shortages in the next decade?
Cautious optimism is warranted. The supply chain is diversifying, new reactor projects, accelerator-driven methods, cyclotron production of Technetium-99m, and domestic initiatives in Western countries. International coordination through the International Atomic Energy Agency and OECD NEA continues. But vigilance is essential. Aging reactors, regulatory hurdles, transport complexities, and geopolitics remain potential choke points.
Thank you for unpacking this dense landscape. It's clear that saving lives with radioactivity requires more than just a reactor running smoothly. It needs diplomacy, technology innovation, regulatory finesse, and a dash of legal savvy.
My pleasure. Legal frameworks and international agreements underpin every shipment, every reactor conversion, and every new production facility. Without those agreements, patient care would literally come to a halt.
That wraps up our 10-minute journey into the global state of medical isotopes in 2024. Thanks for listening, and to everyone keeping these life-saving atoms flowing, hats off. See you in the next one.